Good evening, and thank you for joining us today. My name is Tisha Williams, and I am a proud graduate of Hampton University and currently lead Johnson & Johnson's Global Media Relations team. I'm delighted to moderate today's webinar on mental health. It is a deeply personal topic for me, as I have had many family members who have struggled with mental illness. And after years of serving as a spokesperson following high-profile crises such as the 9/11 terrorist attack at the Pentagon, war casualties in Iraq and Afghanistan, and the devastation following Hurricane Katrina, I was diagnosed with PTSD and depression. Mental health, by many measures, is currently the greatest unmet need in U.S. healthcare. And there is so much misinformation, disinformation, and stereotypes around this topic, which can perpetuate the creation of ineffective policies and legislation and increase anxiety and stigma in many communities, including the Black community. That's where journalists like you come in. We're hoping that by sharing the data and information about mental health, and more specifically depression, that we can properly address a topic that was once considered taboo. So there are 3 data points I want you to keep in the back of your mind as we continue this discussion today. The first, more than half, 57% of US adults with mental illness do not receive treatment. Only 1 in 3 Black American adults obtains the mental health care they need. And finally, Black adults are 10% more likely to report serious psychological distress than Caucasian adults. Yet, Black adults with mental illness receive treatment less frequently than the US average. So many of you know, navigating the healthcare system is extremely tough. And while some progress has been made in recognizing the inequities Black people in the US face, there is still a lot more work to be done, as disparities persist and diverse communities remain disproportionately impacted. Now, many of us know the COVID pandemic did open the discussion more broadly about mental health. However, since then, we continue to see current events like war, racism, the economy, and other challenges continue to impact mental health. So let's bring up the slides. Many of you may not be aware that Johnson & Johnson has been in this space for more than 60 years, working to advance solutions that support patients, providers, and caregivers and communities affected by mental health conditions. Next slide. And one more. So, and we are now working toward a world where mental illness is well understood, rapidly treated, and mostly prevented by 2030. Now, just notice, I said mostly prevented because we may not be able to solve it, but we may be able to prevent it. So I'm joined by my colleague, Dr. Gan Pandina, to talk about mental health. Next slide. Dr. Pandina is a senior director and compound development team leader at Neuroscience at J&J. He is one of the many outstanding professionals working across our neuroscience team to help identify and understand the biological pathways that cause neurological disorders so we can develop new, innovative treatments for patients. Dr. Pandina has spent more than 20 years at J&J, where he has been involved in diverse drug development programs for psychiatry, including schizophrenia, cognition, autism spectrum disorder, mood, anxiety, ADHD, and sleep disorders. He is an adjunct clinical associate professor of psychiatry at Rutgers Robert Wood Johnson Medical School. He is the author of numerous publications in pediatric and adult psychiatry and psychology, and he is actively engaged in teaching and clinical research on the efficacy and outcomes of psychiatric and psychological treatments. He is a licensed clinical psychologist and a member of several international societies, including the American Psychological Association, Association of Clinical Research Professionals, and the International Society for CNS Clinical Trials Methodology. Today, Dr. Pandina is going to share some high-level information about mental health. Before I turn it over, feel free to post any questions you may have during this presentation by leveraging the Q&A box. All right, let's get started. Dr. Pandina?
Thank you very much, Tija. Good evening, everyone. It's really a pleasure to be speaking with you all today. Thanks so much for setting the stage for our webinar tonight. And I look forward to talking with you all about a topic which we often try not to talk about in public society, and that's depression. I'd like to move on to the next slide, please. I think Tija told you about some facts. More than half of U.S. adults with any mental illness do not receive treatment. 1 in 3 Black Americans in the U.S., only 1 in 3 Black Americans in the U.S. get the health care that they need, the mental health care that they need. And in addition, she mentioned that 10% of Black adults are 10% more likely to report psychological distress than Caucasian adults. So we'll talk more about these facts and how they relate to depression specifically in a few moments. If I could go to the next slide, please. Another key challenge that we've faced is during the COVID pandemic, information about depression, declining mental health. This is something that you as journalists are quite familiar on. You've reported it, you've covered it, you've raised one of the most important things for everyone where we start with this process, and that's awareness. People need to be aware that that depression exists, that it's common, that it affects everyone in every walk of life, or it can affect everyone in every walk of life. So we want to partner with you, and we want journalists like yourselves to be sharing information, raising awareness, increasing acceptance and decreasing stigma, and addressing the many challenges that we face when dealing with mental health issues. Next slide, please. So depression has a significant impact on society. In America, 21 million American adults, that's 8.3% of the US population, have had at least one major depressive episode. About 5% of the global population experiences a major depressive episode, and about 10% of people in America overall experience a mood disorder of some kind. 1/3 of adults reported symptoms of anxiety and or depression during the COVID-19 pandemic, which is a staggering number. And when we expand that number to talk about loved ones and caregivers and family members, that means that almost everyone has been touched either by having symptoms of depression or anxiety, having someone that they love, or themselves being affected by depression or anxiety. If I were in a room of individuals, I'd ask, how many of you know someone who has depression, has been treated for depression, or have had depression themselves without revealing anything you don't want to reveal? And almost every hand goes up. Next slide, please. So there are a number of challenges that we face when we discuss depression. And the first of those is that depression is often misconstrued. What do I mean by that? What I mean is that depression, especially in social media, is sometimes portrayed as a phase that can be sort of dealt with wellness or diet, something that will pass on its own, something that everyone experiences. And while mental wellness approaches can be helpful for many, clinical depression is a much more serious condition that requires care from a licensed professional. Second, depression is often painted with a broad brush. That is, many people aren't aware of all the facets of depression and the seriousness of depression, which can leave some people confused about where and how to get help, and even when to get help. And lastly, depression is largely seen as an affluent white condition. And that's simply not the case. When we know that depression does not discriminate against by race, age, gender, socioeconomic status, or identity. Next slide, please. Let's delve in a little bit more how depression is misconstrued. Next slide. So depression is often described in lay language, that is in common terminology, as feeling sad or blue. Whether everyone at some point in time in their life might feel sad or blue, whether it's during the pandemic when we had a much greater incidence of people having those symptoms, or if someone has a serious illness or the death of a loved one, if they have financial problems or issues at work, or having relationship problems, or simply having a bad day or a week. Life isn't always easy, and we all have moments when we're feeling sad or blue, part of the human experience. However, while it's important that people talk about these feelings, and it's important that we're talking more about mental health, the vocabulary that we use in everyday life sometimes doesn't inform people about what real depression is. So I'm going to talk a little bit more about that now. Clinical depression is also called major depressive disorder, is characterized by a series of hallmark symptoms. The first two symptoms, and one of two of these symptoms needs to be present in order to get the diagnosis, is depression, sadness, feeling down or blue, most of the day, nearly every day. The other cardinal symptom is marked diminished interest or pleasure in activities, and again, nearly every day, most of the day. Either one of those two symptoms have to be present. And then you need at least several more of these other symptoms, and that includes significant changes in weight or appetite, insomnia, that is trouble sleeping, or hypersomnia, sleeping more than you'd like or too much, psychomotor agitation or retardation. What does that mean? That means being very behaviorally agitated or slowed down, feeling like you're walking in gum, or walking very slowly, or moving very slowly. Fatigue or loss of energy is a common symptom of depression, as is feelings of worthlessness or guilt. People may have diminished ability to think or concentrate. And importantly, and this is something that I can't stress enough, depression can be fatal. Recurrent thoughts of death or suicidal ideation and behavior are not uncommon as part of a constellation of symptoms that come from a major depressive disorder. So depression is serious. It is a medical condition. It's a biological condition. It's not merely a situation or a phase that someone passes through, and it's something that requires serious care. As I mentioned before, depression isn't something that you snap out of. It's not something that's part of a personal weakness or insufficiency of someone's character. And it's a serious medical condition, just like any other physical ailment. I mentioned that depression and other mental health disorders can occur at any age, but they frequently occur in late adolescence or in young adulthood, when individuals are just often starting to experience their most productive and independent years. That time when you're growing into an independent young person, going out into the world to have your first job, to develop your first relationships, maybe to have a family. All of these things can be seriously affected by depression. And in fact, more than 50% of people who experience depression can experience it in early to late adolescence. And the majority of people experience it by young adulthood. So that's why depression and other mental health disorders are sometimes called the disorders of the young. Although that's also a misnomer, because depression also exists in adults and the elderly. Next slide, please. As I mentioned earlier, depression is often painted with a broad brush. That is, depression is a serious condition. It can be a chronic condition, like diabetes or heart disease. It should be treated as such. It should be taken seriously. Seeking professional help and getting into treatment when symptoms appear is incredibly important. In the same way that cancer can't be considered just one disease, there are many different types of depression, and each should be diagnosed and treated accordingly. You can go to the next slide, please. So I mentioned before, actually, could you go back one slide, please? I have a couple more points I want to make. So while some people can experience clinical depression as a single episode, meaning it's the first and only time that they have a depressive episode, it may only occur once in your life. Although episodes usually last, a couple of weeks or much, much, much longer. But others have recurrent depression. That is, depression comes and may receive treatment and then may recede, and then you can have a relapse later. It can be something that people struggle with lifelong, and may get treatment for at different periods of time over their life. When people don't respond to at least 2 or more traditional antidepressant medications during the same episode, they may have a condition called treatment-resistant depression, or TRD. TRD affects about 1/3 of the population of people with major depression. And TRD is especially challenging because, as the name implies, people aren't responding fully to their treatments. They're still experiencing their symptoms of depression. That can often lead to people feeling like it's their fault, blaming themselves for not responding to the treatments that are given. But the fact is that although many treatments exist, we cannot predict well right now which treatments are going to be effective for which people based on how they present, based on their clinical symptoms. And that's a real challenge for the treatment providers and for patients and people who are experiencing depression. It's also important to, as I mentioned, to note that depression can be fatal. In 2017, suicide was the second leading cause of death in Black American adolescents aged 13 to 19. The second leading cause of death. That's an incredible statistic. So while the symptoms of depression can sometimes appear to mimic those of sadness or the stresses and strains of day-to-day life, please know that depression is serious and it can have serious consequences if it goes untreated. Next slide, please. Thank you. I mentioned my third point was that depression is largely seen as an affluent white condition. And this is simply not the case. We know, as I mentioned in my opening, that depression can occur at any age, children, teenagers, adults, and the elderly. But it's important to note that over 16% of Black Americans reported having a mental illness in the last year, and only 1/4 of Black Americans seek mental health treatment when needed. So it's a huge challenge. I think it's an even bigger challenge because many people, particularly people of color, don't often see themselves represented in the conversation, which can further stigmatize the disease. And stigma, although there's greater awareness associated with depression and mental health now, stigma is still a #1 cause of people failing to talk about their depressive symptoms and not going ahead with seeking care. Stigma continues to be a leading cause of not getting treatment. Helping to better understand the symptoms of depression can help turn the tide on the stigma and help to promote more help-seeking behaviors in individuals when they're experiencing symptoms. Psychotherapy and medications can be very effective in managing the symptoms of depression. Tisha mentioned this early on. But this, not only just treating the symptoms, but reducing the significant morbidity, that is, trouble in daily life, trouble with work, trouble with family relationships, trouble achieving their goals, but also mortality, including suicidal ideation and behavior. And outcomes are improved when treatments are made available as early in the course of the disorder as possible. Next slide, please. So I think Tisha is going to talk a little bit about some of the healthcare practitioners and resource perspectives. But one thing I want to mention before I stop my portion of the talk is that we often get asked, as a clinical psychologist, I get asked, what do people want to know? Who have a family member who has maybe struggling with depression or mental health issues. What can they do to help help their loved one, or help their friend, or help their family member? And the first thing that I always tell people is listen to them. Let them know that you're there. Let them know that you love them, or that you care for them, that you're there for them. Create a safe space, non-judgmental space for them to talk about what they're facing. And then encourage them to get help. Encourage them to reach out to others. There are many, many resources, which we'll talk about in a minute, that are available to people. And those resources are available in times of crisis, or in times of need, to everyone. And the only way that we're going to help to turn the tide and get more people the care that they deserve is to help move the needle on destigmatizing depression in ways that help to normalize help-seeking behavior, especially within communities of color. So with that, I'll turn it back over to you, Tisha, for some closing remarks, and then we can move on to some questions.
All right. Thank you so much, Dr. Pandina. So we hope you found this overview helpful, and please consider Dr. Pandina and my team or myself as resources should you need more background when reporting on depression or mental health generally. And in addition, we are sharing the two clinicians that are on the screen, their information. They are also passionate about breaking down barriers and stigma related to mental health conditions, particularly for people of color. Lisa Harding, Dr. Lisa Harding is a board certified psychiatrist and depression expert based in Milford, Connecticut. She is a bilingual practitioner, and she has particular sensitivity to race, language, and culture, providing culturally appropriate mental health services to diverse and historically underserved populations. Cami Harris is a board certified physician assistant based in Raleigh, North Carolina, and she has a passion for providing her patients with a holistic approach to care. And as Dan mentioned, many people, including myself, have found it helpful to seek care from a healthcare provider who looks like them. And, just speaking from personal experience, this was an issue that I had after seeking help during and after COVID, trying to find an individual who looks like me and who could potentially understand me and some of my challenges a bit more. So online tools such as Psychology Today can help individuals receive culturally competent care, which is often lacking in the Black community. And next slide. And then there are other resources to consider for background information, and many of them are listed on the screen, including NAMI, National Association of Social Workers, SAMHSA, and Mental Health America. And I just want to remind everyone that there is now a new hotline for patients who are experiencing active suicidal thoughts, and it's 988 Suicide and the Crisis Lifeline, where you just call or text 988. And so now I want to open the floor to questions. I see that we have one in. We are happy to answer questions about the information that was discussed today. I will say we're not in a position to provide information about prescriptions or diagnoses. But with that, let me just take a look at one of the questions that first came in. And Dr. Pandina, it is, what type of depression do you think is more common with college students?
So college students typically feel, college students who experience depression will often have a major depressive episode. And that depression can certainly present with different types of symptoms. They can have trouble functioning, trouble with their social relationships, start to withdraw. have difficulty keeping up with their schoolwork because they have trouble concentrating. They might have trouble sleeping. It's also not uncommon to have comorbid anxiety symptoms with depression, and so that's common with separation. When young, older teens go off to college and they're living in a strange environment and having to take care of themselves for the first time and not having that family environment to support them, and have to also manage their own day-to-day lives. So college students do experience major depressive disorder or a major depressive episode. That's not uncommon. But many, many more college students beyond those that would be diagnosed with depression or major depressive disorder experience an unhealthy amount of depression and anxiety and stress. And so college counseling centers are really excellent places for them to get care. Going beyond your question a bit, but that's an excellent resource to reach out to. And sometimes having those initial contacts can be helpful, just to check in and see if the symptoms that they're experiencing are normal. And differentiating between whether or not their symptoms are, requiring long-term or focused treatment from a mental health care professional versus maybe responsive to some supportive care is an important part of that successful negotiating that college experience.
Thank you for that. And I just want to provide a follow-up that is a little bit more specific to individuals that are currently within the workplace. And so there may be job stressors, microaggressions, being asked to, being in some situations that may be untenable. I mean, just because of the stress of the environment, the stress of the job, family life, and so forth. So what steps would you recommend or to seeking that help, or what should we look out for, and at what point should we try to seek help?
So one of the most important things that I tell people who are wondering whether or not they're experiencing mental health symptoms of concern is don't wait. It's perfectly acceptable to talk to your primary care physician. In fact, primary care physicians are actually pretty good diagnosticians and pretty good at saying whether or not they think your symptoms might require more care. That's a really, really good resource for people to start. So it is important that you reach out to someone and talk about your feelings, and even to talk about it with a loved one. Sometimes when we experience these feelings of stress and depression, we internalize them. We think we minimize the importance of them, and we don't give voice to them, or we think people are going to think that they'll use a pejorative, but people are going to think we're crazy, right? People are going to think there's something wrong with us, or people won't believe me. I have a great life. I shouldn't complain. I have a job and friends and family and relatively healthy. So part of what depression can cause you to do is to not think clearly. And so it's really important, if you start to have those feelings, to reach out to people. Some people notice, you mentioned early symptoms that people might experience. They might have trouble sleeping, or they might sleep too much. Their appetite might change. Their energy level goes down. That's really, really common one. They may get angry instead of feeling terribly sad or irritable. And if you notice those symptoms in yourself, and those go on for more than a week, or there's no cause that's obvious to you beyond the stresses of daily life, that's a time when you could reach out to someone to ask them to talk about things. And so really important, most important that you ask early and often to talk about your feelings like that.
Wonderful. Thank you for that. Um, so another question that came in is building on what you were talking about earlier with regard to those three challenges that you've seen. How do you think the media can better cover mental health issues young Black Americans face?
Yes, it's a great question. I think, firstly, as I mentioned, both awareness and information are really critically important. So we want to get out there the fact that depression is a serious medical condition. It's common. Go with the facts. There are a lot of very good tried and true sources of information, um, talking about both depression in general and also depression, and specifically the statistics around depression in the Black community. Um, I think it's important, particularly when we're talking about people of color, to talk about stigma, and the fact that the world is not always a friendly place, and the fact that people of color also do not see themselves represented in the healthcare community at the same rate as they are. In the population, only 4% of psychologists in the United States are African American or Black. Um, you know, as opposed to the population, which is 14%. So it's not, and there's in general a shortage of mental health providers. So I think it's important to also address stigma and address the fact that um, you know, depression isn't something that if you are stronger, you should just get over by yourself. It's a medical condition that requires treatment. You should seek that treatment out, and it's okay to get treatment. And the earlier you get treatment, the better the treatment outcome can be, and the more likely you're going to return to your, your productive life. I think another comment, Tisha, that you made is that here you were working for many years in war-torn environments with incredibly stressful, um, you know, places. Um, you know, I think we often experience the world now through social media, and uh, and hear and see terrible things, all day long. If we have a depression, a major depression or depressive uh, symptoms like that, those images, those things can also become a part of your of this hopelessness that you can feel with depression. The world is never going to get better. I feel terrible. The world is a terrible place. So it's why I think it's also important, um, to think about the impact of just this constant barrage of information that's often negative or stressful that people are hearing about. Um, I also think it's important to talk about the statistics of people of color not getting treatment, and experiencing and the role that the medical community and um, has played in making it more challenging for people of color to seek care. That there's been a long mistrust of the medical profession, not having the best interest of communities of color at heart, and I think that's dramatically changed, in the past 3 to 4 decades, but it still remains a challenge for people to get the care that they need. So I don't know if there's anything that you would add, Tisha, from your experience in that to seek care.
No, I echo that. I mean, it is very tough to seek to obtain care from a institution that we have had a very challenging relationship with, as well as find an individual practitioner that you can trust. I know that one thing that you and I have spoken about a few times is just how the American public or society in general or the government has, unfortunately, the funding that had gone into mental health programs is not it's not as robust as it used to be. So, would you mind talking about that for a second? Because I also believe that that plays a part in what is happening. So, because we may not have those publicly funded programs or those federally funded programs, many individuals in the Black community are winding up in jails or in prisons or in other institutions. Can you speak about that and the correlation there for a moment?
Yeah, it's an incredibly important point. So many years ago in the 70s and 80s, in particular, we had state mental health facilities that offered state psychiatric hospitals that offered care, and um, these there were concerns about the quality of care being offered at these places, and many of those institutions were closed down. The plan had been for there to be governmental funding to fund local and regional community mental health centers that would support people with serious and persistent mental illness, including depression, but schizophrenia and bipolar disorder and other serious psychiatric illnesses. And um, those resources weren't allocated at the level that they needed to be, and because also of significant disparities in access to healthcare and access to affordable housing, those issues also contributed to people not having the ability to seek the care that they need for mental health conditions. We see that in the large percentage of homeless people, who unhoused people who are have mental health conditions and need mental health care. And unfortunately, what has happened over time is, while there are psychiatric hospitals, there are outpatient mental health centers and intensive treatment centers, and outpatient care has become available for some. The largest providers of mental health services in the United States are jails and prisons. It's where the highest percentage of people, the largest ones, receive care. And that that statistic is, of course, made even more important because the rate of incarceration is much higher in communities of color. So if we think about the disparities, the inequities in care, healthcare, the particular fact that mental health care was carved out of many healthcare plans. So until very recently, many healthcare plans didn't have mental health as part of their coverage that they offered, or very minimal care. That systemically has led to an even greater lack of access to mental health care. While that's starting to be corrected, and it has been corrected with some recent governmental policies around mental health, that it still resulted in many people not receiving the care they need.
So it's interesting, this statistic that you just provided, or the piece of information you provided, the largest provider of mental health care in the US, if I'm saying this correctly, in the US are are prisons. Is that correct? Or jails? Okay.
So some of the largest facilities,
Some of the largest.
Giving mental health treatment. Yeah.
And so the question that was asked earlier, what can journalists do? Sometimes these issues go unreported or underreported, correct? And so, to the extent that we would like to shine a light on mental health, especially now that it is not as um, sensitive, if you will, to talk about, you may be able to get more individuals to provide some information about what has occurred and why and so forth, especially state legislators, federal legislators, and so forth. Another thing, I mean, I know you can't speak to the care that is being provided in these institutions, but when you are dealing with a large number of individuals within a jail or prison population, I would suspect that the ratio of practitioners is perhaps lower than what it would be if if the individual were just in public or society, whatever. And so perhaps that even speaks to the quality of care that is being received.
Yeah, I can't speak to the ratio in any specific facility, but certainly I think the challenges of the better providing better mental health care um, across the board to anyone who needs it um, will result in much fewer people having crises that need that are unsuccessfully negotiated or that result in injury or arrest. I worked in acute psychiatric services and acute psychiatric service screening center, and you know, uh, it is not uncommon that people who have that significant distress and become a danger to themselves or others need to be, one of the first lines of defense is the police in order to keep people safe. And um, if people are not reached in time, if the crisis goes on too long, sometimes people get violent, but more often than not, they might harm themselves, or they might make a poor decision, they might get in their car and drive um, uh, erratically, um, and this can lead to unnecessary confrontations. So, and that can can snowball to people instead of getting good medical care, mental health care that helps to address their issue. There's a situation, a crisis situation that evolves and ends up in a legal situation. And sometimes that might be a case where the police have to intervene. So while while that cascade of events is one that I've seen many times, and that continues to play itself out in people who don't get the care that they need at the time that they need it. And I think this goes back to um, people's the stigma of mental health being uh, a concern. People with mental health conditions are violent. The vast majority of people with mental health conditions are not violent. Um, the vast majority of people with mental health conditions, simply need good medical care, and they need it in a timely fashion. And if they were getting it, you know, it, early on when they needed it, the likelihood of them, you know, developing treatment resistance or serious significant morbidities as a result of not getting good care could be avoided.
I'd like to just dispel perhaps a misbelief or a belief rather that may be common in multiple communities, not just the Black community. But if I decide to, there's always some concern about approaching a loved one who we believe may be suffering from mental illness. We don't want to incite them. We don't want to make this matters worse. Like if I feel like they are depressed, I don't want to make them even more depressed by bringing up that word. And so there's this increased anxiety of even speaking to the individual about the situation. Can you is there, as a practitioner, someone who's studied this for many years now, is there any concern? Is there any truth behind that it could make matters worse?
Yeah, it's a great question and a very common misconception, Tisha. Um, that if I talk about people's depression, they're going to become more depressed, or if I ask them if they want to hurt themselves, then they're going to be more likely to do it. In fact, that's not true at all. Um, Talking to someone about suicide or about self-harm or about their depression is not more likely to make them uh, uh, try to harm themselves or to make their depression worse. Um, People may cry, they may become upset, but you're not going to worsen their medical condition by talking about them. In fact, the opposite is often true. People often are alone with their feelings, and um, you know, classic texts used to say depression is anger turned inward, right? Not quite accurate, but it's this introspection, this self-thinking, this focus on I'm a terrible person, the world is terrible, it's always going to be this way, a negative view of myself, a negative view of the world, and a negative view of the future. That means people with depression are often quite um, isolated in their thoughts. Talking about it actually improves that. That's one reason why psychotherapy by a licensed psychologist or clinician um, can be helpful for people. We have ways to help you to dispel those negative emotions and those negative cognitions, to teach you how to understand uh, yourself, your symptoms, um, and in combination with medication therapy to improve outcomes. So yeah, but talking to someone is not going to make them worse. If anything, it's going to help uncover the need for care, and then connecting the next dot. How do you get care? Um, those resources that you talked about before, crisis hotline that everyone has access to in the U.S., connection with a local crisis center, the 988 number, lots of other resources that you've mentioned and that we can provide for those who are interested on the line as well.
Wonderful. So I know we only have about 10 minutes left. If there are any other questions from participants, please feel free to put those in the Q&A box. While we're waiting, one quick question. Can you provide the differences between some of the, you mentioned psychotherapy versus therapy and so forth, and I'm not sure that everyone knows what the differences are and why would one be prescribed over the other, or do we as patients need to determine what type of therapy to seek?
Yeah, great question. So one first distinction I'll make is between psychiatrists and psychologists. So psychiatrists are medical doctors that are trained in psychotherapy and prescribing medications that can be helpful for psychological and psychiatric conditions. So they're medical doctors. Psychologists are trained in providing psychotherapy. And now there are different approaches to psychotherapy. There are different schools that many of which have been shown to be equally effective, like psychodynamic psychotherapy, cognitive behavioral psychotherapy, humanistic psychotherapy. Psychologists are typically have a PhD or a PsyD, which is the same kind of degree but more clinically focused, and they can practice independently. There are other licensed psychotherapists, though, who provide psychotherapy care. Similar kinds of therapy to the ones that I've mentioned that psychologists provide. And that's masters in counseling, social workers, psychiatric nurses who can also prescribe medications, nurse practitioners who can also prescribe medications they've had and they're medically licensed. So it's not important for you as the treatment seeker to determine who should provide your care. The best thing to do is, first of all, just talk to someone about it. Could be your primary care physician, could be your health plan if you have health insurance. We'll have a list of providers that they authorize for you to access. Or you can also simply go online to one of the many resources we have. There are many hotlines that you can talk to someone about what kinds of resources you might need. They can help you to connect you with those resources.
Wonderful. So another question has come in, and it's what is one misconception? I'm sure there are many, so if there's more than one, but what is the top one misconception about mental health that you think people should be aware
Um, the one that I've heard most commonly, either in uh, patients that I've treated over the years or in supervisees that I've supervised and who are seeing patients, is that people think that they're not going to be believed, or that what they're experiencing is not right, that it'll just go away on its own. And that's usually born out of fear, right? Or concern, or lack of knowledge. And that, because it's so popular and talked about in the popular press a lot now, mental health has been in the news a lot. I think people are concerned that someone's going to judge them very harshly for the thoughts that they're having, the feelings that they're having, and so they shouldn't tell anyone. And that's probably the number one concern that I've heard from people, is people, they're going to think I'm fill in the blank pejorative term. I'm not right, or I'm a terrible person, or I'm crazy, or nothing's going to help me. So I know you asked for one, but those often, those three go together. No, they're not going to be able to help me. They're going to think I'm a bad person or I'm crazy, and um, and what I'm thinking is wrong, or it's not important somehow. I shouldn't tell anyone that, because no one else has ever had that experience.
or you mentioned even just being weak, just some people may even feel like if they express this, people may judge them as being weak. And you made a very good statement when I spoke with you at some point earlier about weak perceived weakness versus resilience.
Yeah, it's really important, and I think especially in cultures or communities where strength is so prized, um, somehow depression or anxiety is perceived as weakness. These are things I should be able to push through on my own. And in fact, recognizing that you're having this, getting the help that you need can cause you to be resilient, can help you bounce back from that faster. It's amazing what we can accomplish as human beings when we put our mind to it. And that goes, to the how we can respond to and come back from a crisis, or from terrible things that happen to us. So, equally so of serious conditions like depression.
Oh, well, thank you. So we're almost at time here, and want to be respectful of everyone's Wednesday evening. But I do appreciate everyone joining us today. And Dr. Pandina, I am very appreciative of you providing your insight and information as well as experience to the participants and others. For everyone that's attending, please feel free to reach out to our organization if you have any questions with regard to mental health. We recognize that this is not a sole effort on behalf of Johnson and Johnson. It takes a village, it takes a team, and we work with many individuals to include the practitioners we mentioned earlier, a number of nonprofit organizations, as well as so many others. So with that, thank you everyone for joining, and please be safe and happy holidays.
Thank you so much, TJ.
Thank you.